Welcome, everyone. I think we'll get started. Good to see you all. Thank you so much for joining us today for our Compassion in Action webinar entitled Compassionomics, the Case for Compassion. We're thrilled to have you. I'm Stephanie Adler-Yuan. I'm Director of Programs here at the Schwartz Center for Compassionate Healthcare. And just quickly to introduce ourselves, as many of you know, we're a Boston-based nonprofit organization established in 1995 to advance compassion in healthcare. I honestly think we'd be hard pressed to name someone whose work is more aligned with our mission than the speaker we have with us today, and we'll introduce you in just a moment. Before we do, I want to share with everyone some recent news about the future of the Schwartz Center that we're very excited about. So over the past 2 years, I should say, our team has had the privilege of working very closely with the Dr. Lorna Breen Heroes Foundation to advance awareness of the challenges facing the healthcare workforce and to inspire more meaningful support for our healthcare colleagues, for their mental health and well-being, and for everything they do. Last week, we announced that we're working towards a formal affiliation with the Lorna Breen Foundation so that we can together offer more and more impactful solutions for our healthcare system, and of course, more compassion for those who give and receive care. As valued members of our community and partners in our work, I invite all of you to learn more about our plans as they evolve and to register for an information session this summer to share your thoughts and questions. You can find more information at healingourhealthsystem.org, and we'll pop a link in the chat for anyone who's interested. Okay, and now back to the task at hand. So before we jump in, I just want to note a couple things about today's webinar. First of all, today's program will be 60 minutes long, and we'll have a conversation for the first 40 minutes or so, and then we'll have some time for questions. And there are so many of you on the line. I know we'll have some fantastic questions. You can enter those in the chat or in the Q&A pane throughout the discussion. And last but absolutely not least, I want to acknowledge that the Compassion in Action webinar series, which has become so beloved, has been funded in part by a generous donation made in memory of Julian and Eunice Cohen. So with that, I'm ready to hand this event over to our moderator. Dr. Beth Lown, my dear colleague, is Associate Professor of Medicine at Harvard Medical School and our Chief Medical Officer here at the Schwartz Center for Compassionate Healthcare. I know she's very excited to share this incredibly important work with you today and this wonderful speaker. So take care.
Thank you, Stephanie. And thanks to all of you for joining us today. I'm sure we all agree that compassion matters, but the question really is why, and what are the evidence that there are actually some benefits to compassion for patients, for their family members, for healthcare organizations, systems, but also for us. What do we know that might push us to really accept this premise that compassion really is an important factor in everybody's health. So that's really a lot about what we're going to be discussing today. And I'm very excited to introduce you to our speaker, whose book, Compassionomics, The Case for Compassion, addresses these questions. Our speaker is Dr. Stephen Trzeciak, Chairman and Chief in the Department of Medicine, the Medical Director of the Adult Health Institute at Cooper University Healthcare, also Professor of Medicine at Cooper Medical School of Rowan University. And today is a special day because it's the official publication date of his new book, which is just ordered myself, actually, pre-ordered it. I'm really looking forward to reading it in full, but it's a wonder drug. It's called Wonder Drug: 7 Scientifically Proven Ways That Serving Others is the Best Medicine for Yourself. So I can't wait to dig in and hear a little bit more about it. And thank you so much for joining us today, Steve. It's really going to be fun. I've been looking forward to this conversation.
Thank you so much, Beth. It's an honor to be with you. I'm grateful for the invitation and for Stephanie's intro. And looking forward to the questions today and also having a conversation with you.
Yeah, me too. So I'm going to start at the beginning and just ask you what got you interested in this whole issue of compassion in the first place? How did you land on this? You're an intensive care doctor, right?
Yeah, I'm an intensivist by background, and I still practice. I practice critical care medicine here in the ICU at Cooper. And for the first 15 years or so of my career, I was studying resuscitation science in the ICU. And specifically, my colleagues and I, we had grants to study the optimal level of oxygen in the blood to reduce the risk of permanent brain injury following resuscitation from cardiac arrest. And now we study the science of compassion. So that's a bit of a departure or a pivot, if you will. And really, I wasn't in the market for any kind of change in trajectory, not at all. And I became convicted, essentially, that really the most pressing problem of our time, through my corner of the world or through my lens of experience as a physician scientist, physician leader, and researcher, was that people were, as I looked around, a lot of people were miserable, and it affected how they were treating patients. And you can either posit that that makes no difference whatsoever, or your hypothesis can be that it matters. And our hypothesis, Dr. Mazzarelli and I, that's Anthony Mazzarelli, he is an emergency physician and co-president and CEO of Cooper University Healthcare. And we tested the hypothesis that compassion matters, not just in meaningful ways, but also in measurable ways. And so we went through all the scientific evidence, 1,000 scientific abstracts, over 280 original science research papers are cited in Compassionomics. And we curated essentially all the evidence that compassion matters. And we laid it out. And really then what that led to for me was where the science meets the personal, because I went through burnout myself. And we can talk about that if you like. But what the evidence pointed to was that compassion can be a powerful, beneficial therapy for the giver too. And that what I was taught in medical school, don't care too much compassion will burn you out, was actually wrong, for lack of a better word, and not in line with the available evidence. And so we curated all that evidence, and we got stories far and wide from other people that had the same experience about testing the compassion hypothesis for themselves, where connecting more, not less, was actually promoting resilience and their resistance to burnout. And Dr. Maz and I put our heads together and we thought, there's no way that this is just true for healthcare workers. And that's how we extended our research in the next project that you were just mentioning that was released today, where we curate all the evidence that serving other people actually has beneficial effects for yourself, both your mental health, but also your physical health and longevity, as well as emotional health, happiness, and well-being, and even your professional success. So it's been a long, it's been quite a pivot and change in trajectory, but the last 5 years have been the most fulfilling of my entire career. And I love what we're doing. I love what we're working on.
That's so great. I know you wrote a little bit about your experiment in N of 1, where you were the sole research subject in this little experiment you did. You want to just describe that aspect for us?
Sure. So I want to be real clear about one thing first.
Yeah.
You don't have to be an intensivist to feel burned out. You don't have to be a frontline healthcare worker to feel burned out, especially after 2+ years of a pandemic. I mean, burnout is everywhere. And burnout's like the perfect term, in my opinion, because it's like what's left of a building after it's been gutted by fire, just completely fried and a shell of itself. And that's really what burnout feels like. And it's serious business, albeit it can be a dark place. And what I was taught in medical school, so this was the early 90s, by the way, what I was taught in medical school, and I remember being taught this, of course, it wasn't the overt curriculum, it was what we call the hidden curriculum in medicine. And I was taught, so you won't find this in any textbook or any articles, but this was taught through socialization from senior trainees and attending physicians. And I remember being taught, don't care too much, because too much caring, too much compassion burns you out. And so the teaching was like you had to have this emotional shield, and that it was protective in some way. And I believed that for 25 years until I faced, and by the way, the teaching at that time was based on anecdote and opinion, because there really was no research back in the early 90s. But when I faced burnout myself, I'm a research nerd by background. And so I approached it just like I approach everything else. I try to science it up. And when I went to the scientific evidence, I just was blown away at what research had basically replaced the area where there was just anecdote and opinion before. And what the research shows is that there is, in fact, an association between compassion for others and burnout, but it's inverse. It's inverse. The preponderance of scientific evidence published in the literature shows that it's inverse. So if what I was taught in medical school is true, it would be high compassion, high burnout, low compassion, low burnout. When you look at the evidence, what you see is high compassion, low burnout, low compassion, high burnout. Now, why? Well, my hypothesis is that if you have compassion for patients or for their families or for the staff, for your colleagues, your coworkers, your anybody, you get the fulfilling part of what it means to take care of patients. You get the fulfilling, the meaningful part. You get the good part because of the relationship that flows from that. And if it's one thing that we've learned in our last 5 years, whether it was in Compassionomics or our current project, we learned that the evidence points to the fact that the key to resilience is relationships. And so when you have those relationships that are grounded in compassion for others, you get the fulfilling part. And if you don't have that, if you don't have it, all you have is a super stressful job. And so the conventional teaching that I was taught actually isn't true, or at least I can't find the data to support it.
Yeah, no, I think you're right. I remember getting, like, as a medical student, the essay by William Osler, Equanimitas.
Yeah. Mm-hmm.
And what he stresses is detachment, exactly what you're saying. Don't get too close. It's going to sway your professional judgment if you get to know the patient or become too attached to the patient. And somehow that will make you less of a doctor, And then on the other hand, we have our Surgeon General, who's really, made a brilliant case about the importance of social connection and the adverse effects, the impact on our health of being socially isolated in his book Together. So yes, I'm so excited that this real evidence is just starting to be sort of displayed. Yeah.
What I'd like to point out is that there's an important distinction, and I don't want to be too nerdy about it, but it goes back to neuroscience.
Yeah.
And so compassion is typically defined or at least how I define it, or how it's defined by many researchers, is an emotional response to another's pain or suffering involving an authentic desire to help. So response, help, it's an action.
Yes.
So it's distinctly different from a closely related term, which is empathy. So empathy is like the sensing, feeling, detecting, understanding component. Now, empathy is absolutely vital, because if you don't have empathy, you won't detect, sense, feel, or understand, and you'll never be motivated to take action.
Right.
Compassion. You'll actually miss that opportunity completely. It'll just blow right past you and you'll miss it. So empathy is vital. But one way to think about it is this: empathy plus action equals compassion. And the reason why it's important is that going to neuroscience data using functional MRI. So these are brain scans that can detect whatever part of the brain's being activated at any given point in time by subtle differences in cerebral blood flow. When you have empathy and you bear witness to suffering, it actually activates the pain center of your brain, the pain center of your brain. And so there's actually neuroscience data behind the saying, I feel your pain. And we know this experientially because it's very uncomfortable to watch people suffer, right?
Yes.
But when your mind is focused on taking action to help someone, to alleviate their pain or suffering to whatever extent is possible, the same modality, functional MRI, shows that it actually activates the reward center of the brain. So a distinct neural structure, not the pain center of the brain, the reward center of the brain. And it's associated with positive emotion, positive affect, feelings of affiliation. And that's why what the neuroscience supports is that empathy hurts, but compassion heals. And so I want to go back to what you were saying about Osler. If you are repeatedly exposed to pain or suffering, no doubt it can not only hurt and be painful for you and be uncomfortable, but it could also impair your decision-making. because you're under, because it's actually, there's neuroscience to support it. But when your mind is focused on taking action to alleviate, even in just little small ways, whatever small way you can find to help somebody to alleviate their situation, it's actually activates the reward center of the brain. And so I think that to put all of this together is that taking action can actually be protective against what I would call empathy fatigue, rather than some people call it compassion fatigue.
Yeah, I agree with you.
But yeah, empathy, constant empathy does hurt because there's neuroscience for it. So when you try to do something about it, it transforms your experience, not just in your mind, but actually in your brain, as shown by functional MRI.
So that yes, and that it's a whole fascinating body of literature. I think one thing that I'd love to hear you sort of just think out loud about is, we do have people who are just, like you said, fried, they're burnt out. But what are some of the preventive measures that you can take? So empathy can lead to more distress, sort of, okay, and then get me out of here, the great resignation, or I want to leave, or I just can't do this anymore. Rather than the approach phenomenon of I'm going to actually try to do something, and I'm going to express and demonstrate my compassion by doing X, Y, Z. So how do we stay on the pathway of the compassionate side and intention to help, the motivation? What can we do that raises up that sense of motivation and the approach phenomenon and subdues the desire to avoid, escape, detach, and so forth?
It's a great question and a timely one. So research, and we cover this in the new book, actually, that research from the NIH has shown that self-care practices, we've all received the message about self-care and its importance. And by the way, I don't doubt that for a second, not at all. But our self-care practices over time, and I'm not talking about healthcare workers, I'm just talking about general population. Over time, our self-care practices have become more and more isolating. So what are some examples of that? Put on our headphones and block out the world. Put on our meditation app and go deeply or more deeply withinward, or go take a nature hike by yourself and get away from everybody. And by the way, there's nothing wrong with any of those things I just mentioned, no doubt. But what the research shows is that while that trend has been happening over the last 10 years or so, in decades past, we found solace in family, in friends, in connecting, in relationships, not in detaching and going more deeper into ourselves. We actually took our attention light, rather than shining it on ourselves, we turned around and shined it on other people, and we made more connections. And it was those connections that gave us our solace when we were going through tough times. And so in my experience, what I was sharing with you about going through burnout, I'm a research nerd, so I went to the science, like how do you get out of burnout, right? And so I was looking in PubMed. And what I found was, besides the research I already shared with you about human connection being an important promoter of resilience, it was advocating for things that were like escapism. And so, get away more, take more vacations, go take more nature hikes by myself, but just get away. And so the reason why I wasn't buying it was because the message that you get from those techniques, and not that they're not important, it's good to have vacations and it's good to have all these things. Work-life balance is absolutely necessary. I think that's a settled matter. But what the message was sharing with me is, if I just got far away from my patients, as far as possible away, as often as possible, then everything would be fine and good cheer would magically replace it. And I wasn't buying it, because I thought that something had to fundamentally change at the point of care, not an escape. And that's when I became aware of the evidence that compassion could be a powerful, beneficial therapy for the giver too. And that's when I did my N of 1 experiment. And I want to be clear, it's not just with patients. And in my case, because I'm an intensivist and I can't talk to a lot of my patients, it's with their families. It's with their families, but not just patients and families. For me, it was with the staff, the team, the technicians, the nurses who I'd worked with in the ICU for, almost 20 years. Even reconnecting with friends I hadn't talked to in a long time, and definitely my relationships at home and with my family. And so, what the research shows, both in healthcare in our prior book Compassionomics, and then outside of healthcare in our new book Wonder Drug, what the research shows, and we curate all this for you, is that the key to resilience is relationships. And so when I'm feeling burned out, stressed, any of the above, what I do now is I look for relationships, and I look to connect with people more, not less, not putting on my headphones, blocking out the world, not doing, isolating things. I look to connect, and it's helped me incredibly. But I would urge you not to believe that because I said so, but believe it because science says so. I mean, there are 280 original science research papers cited in Compassionomics, and in the new book, there's 250. So, and we put it all there because we just want the reader to make up their own mind. But I think that the available evidence is really overwhelming that the key to resilience is relationships.
Yes, connection, social support. I agree with you. Of course, that's a lot of what we do at the Schwartz Center, is provide that framework for that kind of stuff to happen, those kinds of relationships, community, bringing people together so they don't feel alone with their experiences. It's so important. So I wanted to ask some other questions, maybe taking it in a slightly different direction, but if you really want to change things for your peers, for your coworkers, for your organization, you have to somehow communicate that message pretty widely, and you have to gain some kind of acceptance or buy-in from leadership to make it real by enacting policy, structures, whatever it is, so that you can actually connect with people. We have so many things standing in the way. So first of all, how do you gain that kind of acceptance besides publishing books for those of us, or those who are listening, who are on the ground just trying to get through their day? How do you persuade people who might have authority to change how your work gets done?
I'll add, before I answer your question, Beth, I'll just add one other layer to it.
Yeah.
Is that good operations promotes better human connection. Better operations promotes better human connection in that I often say you can't care your way out of bad operations. Like if your patient has to wait for, an hour and a half in your waiting room, or, there's other operational problems that are making things not worth properly. There's not, it's hard for compassion to recover that. Right. And so we actually put a lot of time into our operations at Cooper. So I'll just give you one example for that.
Yeah.
There's a technology, and please don't ask me how it works because I don't know how it works, but we've got this technology called DAX, where first of all, let me tell you why we did it. My doctors, I'm the chair of medicine, so I'm an intensivist, but I'm involved with all the medical specialties, right? So our primary care doctors, we're talking about, what we call the pajama time, where they're up until late at night every night doing their charts and whatnot. And then it makes hard for them to come in energized the next morning, and, all the struggles with the EMR. And there's tons of evidence that healthcare providers often now are spending more time looking in computer screens than looking their patients in the eyes.
Right.
And so what Dr. Maz and I call eyeball time, like when you don't have eyeball time, like what kind of like emotional cues are you maybe missing from your patients? Because, you know, patients tell us their most private matters, you know, and so it's not just, you know, I actually think it's a public health problem, because I think that when we're not spending our eyeball time and connecting with people, that we may not be getting the right information. It's just suboptimal for everybody. So we've got this technology now called DAX, where somehow it just listens to the conversation in the clinic room. And I don't know how it does this, but it can tell like what is chit chat and just like, you know, and what is actually material to the visit. I don't know how it does it, but it does it. And then at the end of the day, the physician or advanced practice nurse just looks over the visit and then, you know, maybe edits here or there and signs the note. And that's the reason why I share with you that story is we're trying to get better operations to facilitate more human connection. Does that make sense?
Yes, it makes perfect sense.
Now, to also answer your question, like, I give the first grand rounds every year for my department of medicine. And what I shared with the department, and so we're talking faculty physicians as well as resident physicians, and you know, we've got a really big medicine residency here at Cooper. And what I share with them is the message that I want you to take good care of each other. And, you know, of course, training is hard. It's rigorous. It's by design, right? Because they have to know what they're doing when they're done. And so it's going to be rigorous, but I want them to take good care of each other. And I don't mean like they have to be best friends and go out after work every day, right? But you can definitely take good care of each other in the context of our work. And, you know, check in with people. How are you doing? Oh, I heard your mom was sick. You know, how's that go? And the reason why I told them that is because it's not just good for the recipient, it's good for you too. And there's a ton of science to support that. And so cultures of caring, cultures of compassion, this has been studied by a number of people, including Dr. Siegel Barsad, who just passed away recently, sadly.
Oh, I didn't know.
Yeah, but cultures of compassion, where the coworkers are all, they don't have to be physicians or nurses or technicians, like anybody that's supporting the facility, the staff, where there's culture of compassion, there's less emotional exhaustion among employees. But interestingly, what Dr. Barsad and colleagues found is that there's also less absenteeism.
Yes.
So they not only feel less emotional exhaustion, they actually miss work less. Why? Because when you're really stressed and you don't like the environment where you're going to, it's, you know, people are more prone to calling out. Now, also, I want to just, you kind of spoke from like a leadership sort of thing. One of the reasons why it was important for, and this is just sort of a personal note for me. I'll share with you everything I share with you. I can back up with references, except when I tell you it's my opinion, I'm going to tell you it's my opinion. So this is my opinion. I think my opinion is that it's important for leaders to not only know what they stand for, but also to put it out there, right? Because it's important for accountability, right? Because Dr. Maz and I, we curated all the science that caring does make a difference, not just in meaningful ways, but in measurable ways. And now that serving others is the best medicine for yourself, that puts a check on my behavior. And said, not that I, you know, needed it any more than anybody else, I don't think, but I'm very consciously aware of not only that we published that work, but because we curated all the science behind it. And I know what is the evidence-based way to lead my department. Dr. Maz knows what's the evidence-based way to lead this organization of 8,500 employees. It's evidence-based leading essentially. And so I'm it's been helpful to me, not only because I know the science and I want to, like, as a physician, you want to practice evidence-based medicine. I want to practice evidence-based medicine, but we also want to practice evidence-based leadership. And the principles in Compassionomics, they are evidence-based. And so it definitely gives me accountability for how I do my job. The work holds me accountable.
Yes, that's really a very important key principle. And the more you're accountable, the more you follow through, the more authentic you are about who you are, and your actions align with those words and your values, the more people trust you.
I do need to say, I am definitely a work in progress.
Yeah.
Well,
aren't we all? Yeah.
I don't get it right every day for sure. In fact, I can think of one from just a couple of hours ago, which I wish I had a do-over, in terms of dealing with a colleague. I'm definitely a work in progress, but fortunately the science shows that change is possible. That sounds like kind of a pithy, saying, but there's actually evidence behind that. Yeah, change is possible. And so what the research shows quite clearly is that compassionate behaviors can in fact be taught and learned. And so we're not necessarily talking about what one thinks in their mind or feels in their heart, but what they, how they behave towards another person in a way that they can perceive it. That can definitely be taught and learned. We can get better at it. And that's good news for me indeed, because by the way, I didn't used to believe this before we started this work. I thought you were either wired for compassion or you're not.
Yeah, no.
Like it's in your DNA or in the fabric of who you are, or it's not. Either you have the gene or it's not. And that was eye-opening for me, that's just completely not true. Or maybe not completely. Like most scientists say that about 30%, scientists that study this say like 30% might be predisposition, but what that translates to is 70% isn't, right? Yeah. It's in what we learn, and in a nature nurture sort of debate, we can get better at it. And what the evidence also supports, and your viewers might be familiar with Dr. Carol Dweck's work at Stanford on mindset, where she studied in the education domain, a growth mindset is essential. And what she meant by that is a growth mindset. You believe that whatever you're trying to learn is a collection of skills. It's not a trait that you're either born with or you're not.
Right.
So when she studied it in kids coming up through the education system, when kids were struggling in school, if they had a fixed mindset, meaning they believed that intelligence was a trait, not a skill, right, they wouldn't persevere and they wouldn't work hard to get through struggle because they thought they weren't smart. Whereas kids who had a growth mindset, who believed that intelligence was just a collection of skills, they would persevere and they would work harder in times of struggle, and they would succeed on average more often than the people with the fixed mindset. And so what a lot of people don't know is that, although I don't think it's in Dr. Dweck's book Mindset, she and her colleagues have also studied this for compassion. And what they found is the same thing. Basically, if you have a growth mindset, meaning you believe that you can in fact get better at compassion, then you will work harder at it and connect more, especially when compassion is hard. And so I say all this because I don't want any of your viewers to think like I've got a lot of work to do on myself. But importantly, I'm working hard at it every day. So like last week when I was in the ICU, I was working on my compassion for patients and their families, just like I was working on my skills of endotracheal intubation or pulmonary artery catheter insertion.
Yeah.
And I work on it at home too. Anyway, the bottom line is change is possible, but that's grounded in science.
Yeah, and that's really important. There's certainly skills that can be taught and learned. And, some of this is taught by modeling. We take up the behaviors of those we admire, of our teachers, of our coworkers, whoever we respect and admire. So a lot of it is from role modeling. But there are definitely things that can be taught. Listening is probably, if you want to change one thing, it's the importance of listening and how to listen effectively, so that you really understand, and so that you check back and be sure that you're understanding the person's meaning, perception, their emotional set, and so forth. All of that can be taught, that can be learned, that can be improved. So communication for sure, interpersonal connection is something that has to be chosen as a priority. But beyond that, you're right. I'm totally convinced that these are skills that, we can and have taught forever, thankfully, with greater or lesser success, So I'm curious, in a couple of minutes, we'll turn to some questions, but I have some more of my own, I think. And I'd like to hear a little bit more. I know I want to get to the organizational level too, because I really want to understand how do you create cultures of compassion within healthcare organizations. And there are lots of ways to answer this question. But one thing that I think was really interesting too is your colleague, Dr. Mazzarelli, talked about the business imperative for compassion. So I'm going to start by asking a little bit about that, and then we'll get to the whole idea of, well, how do you really change an entire organization's value set in a way that's actually perceivable, that's palpable to people who live there, who are seeking care there. So let's start with a business case, though, and the business imperative for compassion. And if you can just share a little bit about what you've learned about that, and how Dr. Mazzarelli came to that insight as well.
So healthcare organizations that have a caring and compassionate culture, on average, do better than those who do not, as reflected in patient experience scores, which aren't I want to be clear, patient experience surveys, they don't really measure the caring part of healthcare too well, in my opinion. That's just my opinion right there. But they do measure things that, like explaining and listening, and things that probably go in the same direction as compassion. Now, I want to be clear that while there is a business case also for compassion, and all of our, at the end of the day, we have to keep the lights on in all of our organizations, which can be a struggle in such a low margin business. But the business case can't be the why. It's more like a byproduct or a side effect of having a caring and compassionate culture. You also will do better financially. One of the main reasons I think about it in terms of revenue, and I think about it in terms of expense. So the revenue part is fairly straightforward. Patient experience drives business, period. One of the major drivers, of course, of referrals to physicians is people's experiences with those physicians. Same thing for their experiences with healthcare organizations, whether people have a good experience, a meaningful experience, or if they were disrespected and had a lousy experience. But patient experience drives business in terms of revenue, because people want to be cared for. What the research shows, when I'm thinking back to a study years ago now, published in the Wall Street Journal, that was conducted by Pew Research. And what they found is when patients were asked what it was that they wanted from physicians, they specifically asked about physicians in this study. The caring elements of healthcare were at the top. It was all relational stuff. And at the bottom was like where they went to medical school, whereas if you were to ask physicians, that might be tipped upside down, and that might be sort of surprising to people within healthcare, because you might think you would want technical excellence first. But what the research supports, in my estimation, after curating it all, is that people just assume competence. People think that, if you went to school for all that time to be a nurse or to be a doctor, you know what you're doing. Now, we may have awareness inside of healthcare in terms of gradations of competence or whatnot, but in general, the general public assumes competence. And so what they're looking for on top of that is the relational aspects. And so that's what patients want when they're asked. So that's part of the reason why a culture of caring drives business in terms of driving revenue. But in terms of expense, there are a number of things that we could talk about. One is adherence versus non-adherence to treatment recommendations, including medications. Now, this is sort of expense at the system level rather than like organization by organization. But what the research shows quite clearly is if you care deeply about patients and they know that, they're more likely to take their medicine. And it's estimated that non-adherence in terms of avoidable downstream healthcare costs, non-adherence to recommended therapy and medications is at least $100 billion a year in avoidable downstream healthcare costs. So that's one thing. At the individual organizational level, research supports that physicians who, and because this research was done in physicians, that physicians who have better relationships order fewer tests. Whereas sometimes it's easier to just, get the MRI rather than to have a meaningful conversation with somebody why they don't need it, right?
Right.
One of the most tangible, which I talk to my residents and fellows about this while they're training, is that malpractice is, and I want to make sure I say this carefully, whether or not the patient or the family thought that you cared is a primary determinant of whether or not they decide to sue the organization or the physician.
Right. And
everything could be perfect in terms of the technical aspects, but there's bad outcomes when there's perfect care, right? And that's just healthcare. If they think you didn't care, they are way more likely to sue you. And things could have been technically very suboptimal, but if they think you cared, they're a lot less likely to sue. Now, that's not, of course, the why for treating people with compassion. It's a byproduct or a side effect or an unintended consequence. But these are all things in terms of the expense. So there is a business case for caring as well. But of course, it's not the why. It's just, like I said, an unintended consequence.
Right, right. Although there are some leaders that, want to know, why should I care about your caring initiative? Show me the return on investment. That's something I hear all the time. It drives me nuts, but I understand that they want to know why invest in something like this. So, I'd like to hear a little bit more, and I think we'll turn to questions in a second, but how are you going to move your research on the importance of compassion forward? What do you see next?
Well, I just put in a grant last week to a federal organization to start testing the hypothesis that compassion is a healthcare disparity. And you might say, well, it's obvious that compassion is a healthcare disparity. I mean, look at access to care, where people from low socioeconomic status have poor access to care, or we just look at the disparities in every corner of medicine is impacted by healthcare disparities. There's no area of medicine that doesn't have meaningful healthcare disparities. I'm not talking about the systems level disparities. I'm talking about the interpersonal, at the interpersonal level. And anyway, so I put in a grant about that. And really my hypothesis is that many of the disparities that health disparity populations experience may be because of poor relationships. Because what the research supports is that people are less likely to follow instructions and follow up, and for cancer screening, for example, if they think that their doctor or their nurse doesn't care. And anyway, that's what I'm testing right now. Testing the hypothesis that healthcare is that compassion is a healthcare disparity.
Yeah, well, for sure, we know that there's plenty of disparities based on race, ethnicity, and a lot of other factors due to implicit bias. I'm curious how you're going to tease all of that stuff out.
Very carefully.
That's a research question, and also trust. Historical mistrust because the legacy of experimentation on people of color and marginalized communities. That's going to be huge. And
actually, healthcare system distrust is one of the outcome measures. And so the question is, how does compassion for patients mediate trust or distrust in the healthcare system, which is powerfully associated with completing follow-up.
Yes, exactly. So that's going to be super interesting. I'm very excited to read that next paper. So I'm just curious, are you optimistic about the state of compassion, in the world, in this country, in this world today? It's so polarized. It feels so challenging, hostile,
I am hopeful. I am. People say in business, there's a saying, hope is not a strategy, but I think that hope is necessary for every strategy. So the best definition, or I should say my favorite definition of hope is hope is a conviction that despair will never have the last word. And so I'm hopeful because I think it's needed. I think hope is also good for you. We actually cover that in our new book. But I'm hopeful.
I'm glad to hear it. Well, we do have some questions. Let's see what I got here. One question, words matter. What's helped for reteaching folks that compassion fatigue isn't a thing, that it's really empathic distress?
So could you read that again?
Yeah. So you had made a comment that you don't think there, and I agree with you, that compassion does not fatigue. By definition, it doesn't fatigue. So how can you reteach or change that mistaken perception that compassion fatigues? How can you sort of reshape or reframe that mindset that it's really empathic distress?
Yeah, I don't think it's necessarily definitions or nomenclature or I don't think someone is going to reason their way into a different thinking on that. I think that it's more experiential. And what I typically will do when I have colleagues is I'll ask them just to try to connect more and just see how it transforms their experience. But it's the more than the definitions, I think it's the experiential aspect that really convinces people that it's true.
So here's some more questions here. There's someone who's asking about the power of touch, appropriate touch in clinical settings. How does this help with compassion or the experience of compassion?
Well, I can tell you that from experimental science, and so these are studies in laboratories with experimentally induced pain, with like electrical shocks or hot heat or cold therapy. Like, I don't know who volunteers for those kinds of studies, but they do them.
Yeah.
And what that research, in my opinion, consistently shows is that the touch of a trusted other reduces a person's experience of pain. I didn't say, to be clear, I didn't say that compassion or the touch of a trusted other eliminates pain, because it can't do that. But what the research supports experientially, but also clinically, is that it can attenuate a person's experience of pain, at least to some extent that's measurable. And so I do think that touch can be important. Of course, we have to make sure that that's okay with a patient, right? So I I think we have to be respectful of some patients may not want to be touched, but I think that it can be very helpful. And again, it's not my opinion or like 20 years of experience. It's because that's what science shows.
Mm-hmm. It is. It's very important. And it's something that's receding,
Yeah.
No more physical exams. Certainly no more routine physical exam. So there's other questions here. This is another interesting question about the whole notion of resilience being boosted by avoidance or escapism. And one person makes the comment that this sort of is the tyranny of individual responsibility for cultivating resilience. In other words, is resilience really an individual problem, or is it, the problem of a culture or system or the way we structure healthcare? So
I understand that question, and that's an important one. So another way to state that question would be, are we just adding another thing onto the clinician's plate, so to speak, to be responsible for? Now they're responsible for their own resilience. Right. Well, if we rewind to, I don't know, 20 minutes ago or so or more, what I was saying is that we can't care our way out of bad operations.
Right.
So that's why in our organization, we try to be operationally excellent and caring, and they are, they're not mutually exclusive. They're distinct, I believe, but having good operations. And so we don't put our clinicians into scenarios where they are frustrated with in their daily work. I mean, that is, as a leader, I spent most of my morning today working on things that were operational, right?
Uh-huh.
If we do that better, we'll have a better organization that actually then is a better place for the caring part of healthcare to occur. So yeah, it doesn't just rest on the clinician, but at the same time, if you think your CEO is going to make you resilient, I mean, I personally don't, I think there are distinct leaders have to make an operationally excellent organization. And then it's clinicians that have to find their way to connect with people to make their work meaningful.
Mm-hmm. Yeah, no, I think I would agree with you. So it's not a personal problem. And, to an important point also, it's not anyone's fault that they're feeling the way they do, if they're trying to survive in a system that doesn't permit them to care or to connect or to spend time with patients and families so that they can feel the rewards of compassion.
Yeah.
There's so many other questions. It's really very good here. So there's another, let me just see, there's like 14 new messages down here. Mm-hmm. Lots going on in the chat, my goodness. Can
I just comment on one?
Yeah, go ahead.
Debbie, can surgeons be compassionate and skilled technically at the same time? I'm told surgeons are missing that chip. Yeah, I've been told that too. I think it's totally false. I think surgeons get a bad rap. I don't get it. Like some of the most compassionate colleagues that I have at Cooper are surgeons. They're technically excellent too. And sometimes they'll want to have a little gruff exterior, but when you really get down, because I've seen them at the bedside with patients in the ICU, and I know, and I know anyway, I just think surgeons get a bad rap. I wanted to
step in and defend them, eh?
Yeah.
That's funny. A lot of questions about the impact of COVID. And of course, everybody's like bubble wrapped and, can't really see their face or their smiles, no touching, no family members. How did compassion survive through that? Here's one really interesting comment here. Well, let me just get to the top of this one. Chantel, I had a patient in the ICU during the pandemic, and she asked me to please touch her. She just really wanted me to lay my hands on her. compassionate touch is therapeutic. It's so poignant, so moving. What are your observations about that, Steve? And about the impact of COVID in general?
Yeah, so this is we could spend a whole hour talking about that, but we won't. This is my one major take home. And first of all, before I say what I'm going to say, I want to say this. There was nothing good about the pandemic. But there were things that I learned from the pandemic that will be very helpful to me going forward. And that's different from saying there was anything good, because I want to be respectful to all the people that we lost. I mean, with 423 people, I'm sure there's a lot of folks on this that lost somebody. And we want to be respectful of that. But what I did learn was all about, and actually we cover this in Wonder Drug. It's called elevation. So it's something I didn't really know about this. So much of it comes from the work of Jonathan Haidt and others who elevation is this state of emotional uplift when you bear witness to other people's moral excellence or heroism or going above and beyond for other people. And what the research shows is that when we feel elevated as opposed to being degraded, when we're, surrounded by, people who don't do the right thing or whatnot, when we feel elevated, we are more likely to have giving and serving behaviors because it promotes us to want to be better ourselves. And so that's why, I teach my kids, and parents have been teaching their kids this for eons, that be very careful who you associate with. It's also be very careful what organization you join and how you pick your colleagues. And the one thing that I have learned from the pandemic, what I got was elevation, because I witnessed the heroism of our nurses in the ICU, my colleagues, our trainees, just going above and beyond, trying to help people. And I'll never forget it. I mean, I have certain elevation moments of somebody doing that, etched in my mind, in our ICU. And I'll never forget them. And just the thought of, in my mind, remembering those things makes me want to be better, to do better. And so, again, there's nothing good that came from the pandemic, but I felt elevation on a regular basis, and I'll never forget it. I think I'm actually better for it.
Yes, I totally agree. We owe them a huge debt of gratitude, everybody, really. Well, it is 2 minutes before 2:00, and I think we might be out of time. But there's some wonderful, wonderful comments. The chat is so active, and we have just hundreds of people on this webinar. So I'm grateful to all who attended, and we will have a recording of this on our website very soon. We haven't gotten to all the questions, and so keep them in mind. Come back to our next webinar. But I do want to thank you, Steve, so much. And I would recommend, I'm certainly going to read your new book, Wonder Drug. Compassionomics was fantastic. So I'm very excited about getting that in the mail. I think it's going to come today. Thank you. And thank Dr. Mazzarelli as well. And Steph, I'm going to turn it over to you to close us on out.
Thank you so much, Beth. And I think you said it all. Thank you, everyone, for joining us today. Thank you, Dr. Trzeciak, for sharing your incredible work with our community. And thanks to everyone for piping up in the chat. I'm always amazed at how much wisdom we all have amongst all of you. So thank you for sharing that. And that's really it. We'll have another webinar. We'll be back in August. So keep an eye out for more news on that. We'll be focusing on the issues, challenges, and opportunities facing the nursing workforce. So you'll be hearing more about that. And in the meantime, recording should be up tomorrow. We will be sending you a very brief survey. Please take a moment to fill it out. We read every single comment. And we want to hear more about what you want to hear from us. So thank you. Thank you for your commitment to compassionate healthcare. Take good care of yourselves, and we'll see you soon.